Hi everyone, welcome to Connecting the Dots. Connecting the Dots is a weekly Facebook live talk show by aphasiasg that aims to answer all your burning questions about our healthcare system and health services, as well as any questions you might have about brain injury and aphasia. We're basically here to help you connect the dots. Now, to our viewers on Facebook, we encourage you to ask questions and leave comments freely throughout the session. Our guest speaker will aim to answer all your questions before the end of the show. My name is Evelyn. I'm a speech and language therapist and the founder of aphasiasg. And tonight I will be your moderator. So for our finale episode tonight, yes, tonight is episode 10. Our topic is rehab medicine. It gives me great pleasure to introduce Dr. Effie Chu. Dr. Chu is a rehab physician with the National University Health Systems, which is the healthcare cluster that oversees National University Hospital, Ng Fong General Hospital, Alexandra Hospital, and Jurong Community Hospital. Welcome, Dr. Chu. Hi, Effie.
Hello.
Thank you so much for taking time and spending the evening with us. This topic is so important to our community. As you know, with aphasiasg, we support caregivers and persons with aphasia, and oftentimes there are questions about the whole rehab journey and like the whole healthcare system. Why is it so difficult to get services? Where can I get help? So having you on our show is just invaluable. Yeah, so we really encourage.
It's a great honor to be here.
Thank you so much. Thank you. So without further ado, we're just gonna dive right in because we only have about an hour. Tell us what exactly is rehab medicine? Or sometimes we call it inpatient rehab. Yeah.
So rehab medicine itself is a branch of medicine that looks at function. Okay, so for example, the cardiologist looks at the heart, looks at the vessels. The renal physician has got the kidney as the organ. So what organ does the rehab physician have? And our organ is essentially the function of a person. It can be the physical function, it can be the cognitive function. It covers everything, a lot of things, right? So what makes a person be able to do what we do every day? That's the function of a person. So when we talk about inpatient rehab, it's actually the journey that a person has usually after they get one devastating disability, or so for example a stroke. And those who actually have moderate to severe disabilities actually require a little bit longer time staying in the hospital to get more intensive rehab. And so they have to do inpatient rehab. And that's also because the caregivers are not able to care for them at home in their current state. So with better function, then the caregivers are able to cope a lot better. Yeah.
Right.
So the whole journey is multidisciplinary, obviously. So there's doctors, there's physiotherapists, there's occupational therapists, there's speech therapists as well, definitely, right? And of course, the psychologists are involved also.
Right. So these are some of your team members.
Yeah, that's right.
Seen the slides. Yeah. So I see over here we have the OT, PT, ST, MSW, psychologists. Fantastic. Yeah. Nurses, patient. And it's interesting. I noticed that you put patient and family as well.
Yes, definitely. Actually, they should be put in front. So actually the patients and the family members are the ones that should be the ones directing the whole rehab journey. So because it's the patient who determines the goals themselves, actually. And we think that most patients actually want to be as independent as possible. Yeah.
That's very heartening to hear, right? Because very often in healthcare or in the healthcare system, we hear complaints or we hear feedback like they didn't consider my feelings, or I wasn't consulted, or I didn't feel like the team understood me or cared too much about my problems.
Yeah, so the rehab journey should be a very individualized sort of journey for each person. No two people are quite the same, not just the social situation, but in terms of the neurological recovery as well. We are finding that the intricate, differences between people, and their recovery.
So I'm just going to ask a little bit more about rehab, because we also know that there's community hospitals now, and more are being built. So how does inpatient rehab differ from the community hospital then?
Okay, so Well, inpatient rehab, we actually do inpatient rehab in those what we call the acute hospital setting or specialized rehab that is directed by rehab physicians. While the community hospital it has patients staying in as well, so inpatient rehab in that sense. Also in the community hospital, overseen by the family physicians. We cater to a slightly different population of patients. So the ones that come to rehab medicine tend to be the younger population. We usually need them to be able to be able to tolerate longer periods of rehab, so longer sessions. So usually it's 1 hour of physiotherapy, 1 hour of occupational therapy, and an additional hour of speech therapy. They tend to be a little bit more rehab complex. So, for example, they might have very bad spasticity that is getting in the way of their mobility or their ability to do things, or they might have very bad cognitive issues. So those are some of the types of patients that we see, as opposed to the ones that go to community hospital. They tend to be those who are older. What we would, previously we would say it was slower, a little bit slower than the community hospitals. But if you go to community hospitals these days, they're not very slow at all. Yes. But they tend to cater to an older population of patients. Yeah.
Yeah, because we do hear in our community some maybe some patients who were in the acute hospital getting rehab, but some of them actually were transferred to community hospital, and very often the caregivers may not know why. So there's always this burning question about what's the criteria to actually be somewhere, and I think you answered that. Well, at least I think part of it lah. Right?
Yes.
What kind of caseload do you see on the, like what are the kind of cases? It's probably not just the stroke and the brain injury cases, right? There's also different types, profiles of patient.
So yes, so we are like rehab complex would involve like spinal cord injury patients as well. So we also get the younger traumatic brain injury patients. They have lots of cognitive issues, and then some of them have behavioral issues also early on, and then some of them also have problems with arousal. So very early on in the journey, and some of them actually have very unstable medical issues that still require some medical help to oversee. Yeah. So we work closely with our acute colleagues as well, acute hospital colleagues. So they do play a role in our patients' journeys also. Yeah.
Right. Okay. So this thing about rehab, right? I think earlier on you mentioned something about motor learning as well.
Okay. So in terms of the what happens during inpatient rehab, so this is just to say what we are actually trying to do for inpatient rehab. So what we are trying to do is actually to engage patients in neuroplasticity, to enhance neuroplasticity and to enhance motor learning, or cognitive learning as well, and so as to bring about the improvement that we see in a lot of our patients, right? So what happens in rehabilitation is actually that all this neuroplasticity, how do we get the nerves to modulate or to be plastic? It's actually through activities. So for example, the pictures that we see here with speech therapy or with physical rehab, right? All these, what we're trying to achieve is to mold the neurons so that we will improve the efficiency of the transmission. So if you see on the diagram on the left upper corner, it is to illustrate that with activities you can actually improve the synaptic, which is the neuronal connections, the efficiency of the transmissions over there. So on the graph on the right bottom corner, you can see that with motor skill learning, there's an initial improvement in protein synthesis. There's protein synthesis of the neuronal junctions, and then over time, you see that there's synaptogenesis, which just means nerve starting. And then in the longer term, you see net reorganization, which you can see in the left lower corner. The left wall corner just demonstrates the far left is the normal people. What happens when they activate, in this case, the right arm, you see the left side of the brain actually activating. After a stroke, the activation is all over the place in B. And then in C, after training, you see that there's lighting up, a lot more lighting up with training. So this is neuroplasticity in action. Yeah.
That's great to hear. Yeah, we talked a lot about neuroplasticity, and I know one of the frequently asked questions among members of our community, because many of them may have suffered a stroke years ago, and we're talking about even 10 years, 12 years ago, and they ask questions. They ask this question of, is rehab still useful for me? Right? Should I still continue doing therapy or practicing? I mean, what's your take on that?
Oh, yes. I think they should, right? That's the
Yeah,
short
that's what we
answer.
tell them to practice, join us, yeah, have
Yeah.
conversations.
Yeah. So what happens over time is actually that people, people being people, right? So that it tends to be a little bit of a degeneration over time. So this is what we call in term learned non-use. So especially the arms, which if your stroke affected arm is not the best or in the best of shape, your tendency is not to use it. Just forget it, and then do everything in daily activities with a good arm, right? With the legs, it's not quite possible because you can't really walk with one leg, so you have to walk with two legs. So we don't see that as much as long as people keep moving. But over time, we do see this phenomenon called learned non-use. So it's always useful to keep training, right? So that we do not lose the function, whatever residual function there is. And even if it's not perfect, right, the stroke affected hand can still be used as a stabilizer. You can use it to, carry, plastic bags, even if you cannot do writing or you cannot, say, type on the computer as beautifully as before. There is still residual function that can be useful. Yeah. So we would say continue training. Exercise is always useful, right? Physical activity will always put you in a better place. So yes, continue training.
Thank you for that information. So everyone hearing this, you know what to do, okay? Come for chit chat and continue having conversations.
Yes,
Yeah, I mean, we tell them you have to use it, and like never give up, never give up. Just keep trying. Yeah, great. And one question that a lot of members of our community have is, how do you prevent a second stroke if you've had one before? How do you prevent like a recurrent stroke?
okay. So I think we get that question very frequently, right? So especially in the acute setting. So right from day one, actually, that's what the doctors are most concerned about, to prevent a second stroke. So it depends on the mechanism of the stroke in the first place. So for some people, it's an ischemic stroke, which means there's loss of the blood supply, right? Because of a blood clot or whatever it is now, right? Then for other people, it's a hemorrhagic stroke where there's a bleeding into the brain. So we have to control the risk factors. For the blood clot type of strokes, that it could be because of irregular heart rates, or it could be because of high blood pressure, cholesterol issues, or diabetes. Those are the risk factors that we see. So it is very important to control these risk factors, right from the start. So the doctors might be prescribing some blood thinners. So these have to be carried on for in the long term. And then control of blood pressure. So these are the targets that we're looking at. We're looking at less than 140 and 80. So we start medications if it's 140 over 90, right? So BMI, which is your weight, right? So these are the ideal weights that we are looking at. So the BMI should be between 18.5 to 30, or 23, sorry, not 30. LDL, cholesterol, which is the bad cholesterol, it should be less. Okay, so for stroke patients, we are looking at less than 2.6, okay? Because they have got risk factors already. For fasting blood glucose, we're looking at 4 to 8, and actually 7 would be ideal, right? So these are the targets that we are looking at. And also some of the things that you have to do is also to look at the diet, right? So and to also go for regular medical reviews. So these are the things that the doctors will do at the medical reviews, which is to look at the risk factors. So whether you're compliant to the medications, do you need blood checks for the blood thinners that you are on, the blood pressure monitoring, the lipid monitoring, education on the stroke management, and then also to look at your rehab needs. So for example, some people run into pain problems in the longer term, like shoulder pain is very common. If they walk with a funny gait, they get back pain problems, knee pain problems. Yes, and they see whether they have any rehab needs at the time and need referrals for the rehab. Yeah. So hopefully,
yeah. I have one question from a Facebook audience. Mr. Kikun asked, I was on long-term medication for my stroke. Let me just stop share for the screen. I was on long-term medication for my stroke. Does it mean I have to take aspirin and atorvastatin for life?
So the blood thinners, preferably so, yes. Yes, it should be for life unless something happens along the way. We do intend for it to be for life, yes.
Okay, yeah. So I think this is a member of our community. I also have a second question. This is out of curiosity for myself. You mentioned you were looking at parameters like blood pressure. Does it mean that it's good practice for anyone who has gotten a stroke to keep monitoring daily blood pressure or like multiple times a day? Some of them may not have their own blood pressure machines,
Yeah, so I guess if it's stable, it doesn't, you don't need to check the stock market every day, right? People are obsessive, right?
Yeah.
They're a bit obsessive about it, and then if it goes a little teeny bit up, then they get excited and they get anxious, and then the blood pressure goes up even further. But if it's stable, there's no need to monitor it every day. It's probably good practice to monitor it once in a while. Say if it's once a week or so, it does make sense, right? To keep an eye on it. But definitely, if it's like borderline, or if it consistently goes like 150, 160, 180, right? Do go in and see the doctor about it already.
Yeah. You're quite right, because I remember one of my clients, he would get very anxious when it's a little bit above like 130. And he will be bothered by it, and I think it's a bit of a vicious cycle. It exacerbates that feeling of anxiety.
That's right.
And then during therapy he will tell me, I'm very worried, I measured myself this morning and it was over 130. But I think it's I can see why. I mean, it's quite scary, the thought of having a second stroke, and because this topic comes up again and again, you have to prevent yourself from getting a second one.
Yes. I think if it's high and if it's consistently high, just go in and see the doctor already.
Can you share with us a bit about maybe nutrition and diet control in terms of preventing a second stroke?
Yeah, so diet is obviously very important in terms of managing weight and managing our cholesterol as well as the blood pressure. So this is the HAB's healthy plate, which they have publicized a lot, right? So fruits and vegetables for half the plate, fill half your plate with fruits and vegetables. Brown rice for a quarter of the plate, wholemeal breads, right? And meats for another quarter of the plate. So we try and choose low cholesterol, low salt, and low sugar options, right? And drink plenty of water, right? So those are some of the things for diets. And exercise, as a rehab physician, I cannot emphasize exercise more. Right?
How much do they need?
So yes, this is how much activities that is needed, right? So exercise is good for everything, absolutely everything, right? So it's good to lower the blood pressure. It helps with your lipid profile. It will resists the good cholesterol, right? It makes people feel happier. It actually alters mood, right? And if you're physically fitter, you can do more stuff. You're more independent. You can go out with your family a little bit more. Your social interaction is a little bit better also. So in all aspects, exercise is fantastic. So how much exercise, as we said, right, do I need? Okay, so the magic number is 150 minutes of moderate intensity exercise per week, and that works out to half an hour for 5 days a week. So if you are
Really,
so
because I don't get that myself. I'm in trouble, yeah.
oh yeah, join more than half the population of Singapore, right?
Yeah, we all know it's important, but I guess it's about prioritizing lah. Really, it is. I would say, yeah, especially for members of our community, if you have concerns, then prioritize this.
Yes.
Yeah,
So
prioritize this.
I do empathize with our stroke patients because a lot of them have physical disabilities, or even if not physical, like with just aphasia alone, right? So they don't feel comfortable about going out. If they need help, it's not as easy to get help from other people.
Yeah.
So do understand, but still important lah. So there are multiple ways of getting this physical activities in, right? Okay, so this one is just the aerobic exercise. Don't forget the strength training that needs to happen at moderate intensity as well, at least twice a week. Okay.
Yeah.
All right. So in terms of what you can do, it's actually, it doesn't need to be, I need to do the brisk walking for half an hour every day. I must go out of my house, that sort of thing. It actually just lifestyle things, right? So just doing housework, household chores, can also make up moderate intensity activities. Gardening also, not everybody has a garden. Now, people have got, community gardens downstairs. Yeah, so choosing to walk to the bus stops. All these are things that can be done. Yeah, so doing housework like mopping the floor, doing manual work also helps, right? And then for moderate to vigorous strength training, we're looking at lifting, moving moderately heavy objects, carrying heavier groceries. Those are some of the things that can be done. Okay. So as long as we be sedentary less, so watch less TV, right? Even if you watch TV, watch the TV standing up or something, walk around and watching TV.
Everyone stand up now to watch this, stand up now.
Yeah, so every bit counts. If nothing at all, just start with 10 minutes, and that will be a great start already. So if you really feel that your physical disabilities are really an impediment, go talk to your physiotherapist, go talk to your doctor. They would have suggestions that would help. Yeah.
Thanks for that. I think it's really useful to see the breakdown of what kind of like community activities actually constitute exercise, right? We always think of exercise like, oh, I got to go to the park or go to the gym and work out using the machines, but really it doesn't have to be. Even walking to the bus stop or just like just walking downstairs to the kopitiam, that counts, especially if after an acute medical episode, you are mostly homebound. And on that note, I just want to say, because sometimes we see patients with aphasia who only have communication difficulties and not much maybe physical challenges, but then their family members are concerned that they may not be able to get around and hence restrict their activities. If this is resonating with you, if you are such a caregiver, think about what Dr. Chu just said, and perhaps if you really feel very worried, then accompany your loved one downstairs, or if you really cannot accompany your loved one, then just take a leap of faith and say, hey, let that person be a bit more independent, of course with safety as a primary as a priority lah. Safety always first, but if that person can do things by himself, herself, let them do it. I think it's really important to advocate independence.
Our our physiotherapists and occupational therapists all bring our patients out to do community outings. So they would ensure that they are safe in the community, and they will actually tell the caregivers whether they're safe or not. So yes, sometimes we do see that caregivers are a little bit protective.
And I can understand why. I totally see. I'm a caregiver myself, so I can understand the worries and the concerns and the anxiety. But at the end of the day, if we are talking about regaining function and independence, we must allow that person to be active lah. Within safety limits. Yeah, it's important. Actually, we have two questions from the audience. So there's a follow-up question from Mr. Kikun. He asked, is there any side effects for the medications taken on long-term basis? And with that, he means aspirin and statins. Yeah. Any
So So any medication, anything that comes in a pill, you know, there are side effects, but there are bound to be some level of side effects. Yeah. So aspirin's obviously blood thinner. So, you know, the risk that we talk about is like bleeding into the gut. So sometimes it's more difficult to stop bleeding. So these are things to watch out for. So if there's gastritis problems, or you know, any other reasons for bleeding, so just check it out with the doctors, right?
Yeah.
So if there are real concerns, do check it out with the doctors. But do know that they actually prescribe these medications with the risks of stroke in mind, right? So and they have weighed out the benefits as well as the risks, right? So it's always a weighing of the benefits and risks when it comes to taking medications.
Yeah. Thanks for that. We have another question. This one from Hazira. She asked, why is it harder to assess speech therapy as compared to physio and OT and occupational therapy across the acute community and community settings, community hospitals and community setting? Is it because there are not enough speech therapists in Singapore currently? I say this because when my father was at XX community hospital last year, his PT and OT goals were met, but not his ST goals. I was told by the ST that it is unlikely that he would be allowed to stay longer in a ComHos simply because of his need for speech therapy. How can we mitigate this in the future?
Okay.
It's a caregiver. It's a very genuine question from a caregiver.
That they cannot go home, right? So I understand it from both sides, right? So if they have physical needs that for which they cannot go home with, like your caregivers cannot cope, then it makes sense to stay in the hospital. Patients always do better at home, right? So they're more free to move. They're not restricted in the hospital. The nurses are always scared that they fall, so they're put in bed with the bed raised up, so the mobility is restricted. So actually that if they go home, we do find that their function is actually better. Their physical function is better, right? So and we also say that if the patients can go home, that actually, you know, that should be where they should be, right? Having said that, I do understand speech therapy, it's important to get that intensity. So if they can come back to a hospital to get that intensity of rehab, that would be the best situation, right? So our recommendation is actually in the acute period, is actually 5 hours of speech therapy every week, right? So that is the evidence that actually makes a difference for the aphasia patients.
That's right.
Yeah. So if they can fulfill that, that would be great, right? So in an outpatient setting, and we should try, you know, we try to honor that. But in hospital, we actually really try to honor that, right? However, we also realize that the resources are limited, so not everybody might get that 5 hours. And also, if if goals are slowing down, if it comes to like 3 months down the road or 2 months down the road, and the improvement we see, it's slowing down, and we say that, you know, if we train communication partners already, these are the activities that we can continue at home, and we can continue this as outpatient. It is also reasonable in many of such cases to do outpatient therapy at less frequency, not the 5 hours a day, 5 hours a week anymore.
Yeah. And I guess one of the things that she asked was about getting to stay longer in the hospital because of the need for therapy. And I think this is also a recurring feedback from patients that I still want more speech therapy, but somehow I just don't get to stay. You know, like sometimes it could be that they only have aphasia and then they're discharged, whereas maybe somebody else who also had a stroke with a physical impairment gets to stay longer, gets to be warded longer. So there's always this kind of comparison almost.
So if patients can come back, so if they can come back daily for their speech therapy, that would be fantastic. I know in most facilities in public practice, daily outpatient speech therapy is not available. Hence, we do keep some patients for inpatient speech therapy, not very many of them at all. And it's only for a short period of time. Yeah, but then if patients are mobile and can take public transport, we actually would prefer that they come back for outpatient therapy.
Yeah, thank you for that. I think this is always one of those things. And then really, so to answer Hazira, what I know, according to our official numbers, AHPC numbers, right, Allied Health Professional Council numbers, we probably have only about registered 600 SLTs in Singapore, and out of which I think more than half are seeing pediatric population. So you go figure how many there are actually in the adult settings. Not that many, to be honest, compared to our OT and PT counterparts. But you are right. I think there is a growing need for this for our profession, obviously. Yeah. So, well, since we're on aphasia and treatment, what is the current practice in Singapore regarding medical treatment for stroke and aphasia?
Aphasia is speech therapy.
Yay! Speech
Therapy
therapy for the
speech
win.
therapy, right? Yes, so
Neuroplasticity, right? We said.
plasticity, right? So to optimize plasticity, more speech therapy. We encourage more people to take up speech therapy.
Yeah.
So
Here, students, yeah.
yes, so to the students, go and spread the word. Yes. For stroke treatment, medical treatment for stroke per se. Okay, so depending on mechanisms you were talking about, right? So ischemic stroke or hemorrhagic stroke. So ischemic stroke will be blood thinners. Hemorrhagic strokes usually, in most cases, it is due to high blood pressure. Yeah, in Singapore, most of it would be high blood pressure. Some people have got strange malformations in the blood vessels that make it more easy to bleed, but that's the rarer lots of patients.
I think there's an image here. Oh, this is language. Yeah, sorry, this is a language. Yeah.
So what is our treatment for aphasia? Medical treatment for aphasia? Nothing. No medicine has actually popped out really. It's not like no shining lights in terms of medications like. So our gold standard is still speech therapy, 5 hours a week in the initial period, right? So why did I want to show this? Oh, this one was more on the brain stimulation part of things. But before we go there, right? So medication strike. Okay, so some of you, or your loved ones, right, might have run into medications such as piracetam. I think the piracetam, some doctors in Singapore still use it for treatment of aphasia. It's relatively innocuous. It's what's called a neutral pill. It's nootropic, okay, agents, in which means that it is an enhancer. It's a cognitive enhancer of sorts. Okay, so relatively innocuous, as in the side effects profile is actually quite okay. Limited evidence, right? So in terms of large clinical studies, it's not like the influenza vaccine or the COVID vaccine that you see now, right? 95% efficacy, that sort of thing. The other medications that have been tried are like donepezil, amphetamines, bromocriptine. Some of these are used as Alzheimer's medication. Some of these are stimulants. And we've got Parkinson's medications as well and antidepressants. So none of them have stood out as dramatically effective, right? If the doctors prescribe it for aphasia, they would actually tell you, what are the pros and cons for taking it. As always, taking medications is about the pros and cons and learning the pros and cons about it. Okay. So there are drugs that also adversely affect speech and language, which is the sedatives. So which cause drowsiness, and then they can impede learning as well. So we know that speech therapy is an engaging process and a learning process, right? So we want to be at optimal learning capacity to engage the speech therapy. So we usually try to minimize those medications as much as possible if the patients are in hospital. Okay, so
there are two questions. Maybe I'll ask you these questions. But so one, there's a question from Facebook audience, Briner, who says, "I understand that not all doctors recognize the effectiveness of speech therapy. Is that true?" Yeah, I have no idea, but yeah.
No, the doctors would be more than happy to order speech therapy, right? So refer speech therapy.
I don't know if that question is, I don't know if I'm jumping the gun or making an assumption, but perhaps because there are different disciplines of doctors, and is it true that not all disciplines of doctors would engage or refer or blue letter, like speech therapy so much? Maybe that is the train of thought. I don't know.
Yeah, well, it's hard to imagine if that they wouldn't, if a patient comes in with aphasia, especially in the relatively acute subacute phase where there's improvement still to be expected. Most doctors, I think, would even
Yeah,
even
yeah,
the most recalcitrant, I think, would
yeah. I think
unless they don't know how to refer.
I think with regard to acquired communication disorders, especially, like if the person has a communication impairment, who are you gonna call? It has to be a speech therapist, I think. Yeah. I think it's quite we see increasing referrals lah in the acute setting, subacute setting, which is very promising. Yeah, but
Yes.
there's also other considerations, I suppose, also with swallowing and all that. Yeah.
Yeah, so I guess unawareness is still an issue
Mm,
for doctors.
mm,
So, for example, if
mm,
it's cognitive communication deficits,
mm.
sometimes it doesn't get referred to the speech
Right,
therapist.
right,
Yeah.
right.
So
Yeah,
yeah. So it's also knowledge and awareness.
yeah.
Some doctors are not tuned into the patient's function as much. So, for example, if they're looking at the toe or gangrene in the foot,
Mm,
right, they might not
mm.
be so aware of cognition and speech and language. Yeah.
Absolutely. Yeah. Yeah. Thanks for that. Thanks for the shout out because we do sometimes right now I'm working in the community setting as well, part-time. So I work in a day rehab center where I work mainly with the young TBI, young stroke population. And it's surprising to me that sometimes, like the ones with cognitive communication needs are missed out in the acute setting.
Mm.
Sometimes,
Yes.
sometimes
Yes.
it happens. As in they are not referred to speech
That's correct.
or very very much later. They get missed
Yeah.
out
Yeah.
almost. Like it
So,
happens.
so yeah,
Yeah.
physical deficits are obviously a lot more in your face
Mm,
than the cognitive and speech language
right.
problems. Yeah.
Right. Yeah. So then there's a second question about neuro aid. Is it something recommended? I know that's a bit like a TCM type
Yeah. Yeah.
medication.
Yeah. So it goes into the bag of the other medications as well, right? So little evidence, right? Limited evidence, right? If the doctors give it to the patients, they will come with information as well. The evidence is limited. You take it if you want to. Yeah.
Yeah. And since we're on the subject of, neuro aid and TCM, what's your take on TCM actually, because
Yeah.
we always get questions like, oh, should I have acupuncture, 推拿, massage, what's your take on that?
Yeah, so my standard answer to the patients is acupuncture. If you're aware of the side effects, just be aware of a few things. I mean, they're obviously putting a needle, so if there might be risk of bleeding and bruising if the patients are on blood thinners, right? So just be aware of those things. So the acupuncturists do have definite places where they acupuncture, so they could do a scalp acupuncture for aphasia, or they do tongue acupuncture for aphasia. So you go to an acupuncturist that is licensed, that has got good reputation. Because I have no, training in that area, so I can't really counsel you as to who is better than who, right? In terms of acupuncture. Yeah. But acupuncture is fine. A few things, all those cupping issues are the same thing with the bruising issues are, right? And then also, medications. If you're thinking about taking TCMs, some of the medications actually interact with the blood thinners. So that's the place to be
Right,
aware.
right.
So,
Do-
we usually tell them don't do the
mm,
medications.
mm. do you know which are the ones that react with blood thinners? Just because we know so many of our members are on blood thinners. Which are the, do you know offhand? Is it?
No, my knowledge of PPM not so good.
Okay, but just so note so remember, if you're going to take any Chinese herbs or tonic, just make sure that it doesn't interact with your blood thinners. Yeah, good point. Yeah, really good point. Well, okay, thanks for that. And then I guess another question that always comes up would be about brain stimulation. What's the latest evidence about brain stimulation activity? In fact, during the Aphasia Awareness Month, we screened a Netflix movie as part of our awareness raising. So everybody came online to watch it together. The movie is called My Beautiful Broken Brain, which featured a lady who suffered a stroke at the age of 38 and aphasia as well. So because she is in filmmaking, she documented her journey with video snippets and put it together as a documentary film, and it's available on Netflix. And one of the segments was actually about brain stimulation, which got a lot of our members excited, obviously. Yeah, so I think, yeah, I'm sure you get this question a lot also lah. Yeah.
So anybody who can surf an internet, and has a loved one or themselves have aphasia, they would come up with this thing. Yeah, so that's where the slides come in. Okay. so we are looking at the so the area of concern, right? So in the previous slide, on the brain area that is affected by aphasia, it is actually the frontal, inferior frontal, which is on the left side, right? Okay, so on the left frontal area, inferior frontal gyrus gives you a Broca's area, and then a little bit further at the angular gyrus is where the Wernicke's area is. Right, so the temporal lobe is involved to get auditory stimuli, previous slide, sorry. And the angular gyrus integrates all the sensory input, right? So what happens? Okay, so brain stimulation. Sorry, even could you go back to the previous slide now?
Yeah.
So these are the types of brain stimulation that we have. On the left is transcranial magnetic stimulation. On the right is transcranial direct current stimulation. The magnetic stimulation, you see the coil at the left bottom corner. That actually has got electricity running through it, and then the electricity actually generates a magnetic field, right? So if you remember secondary school physics, that's what happens, right? The magnetic field actually then creates eddy currents that gets conducted. If you put it over the brain, it's actually electrical currents that it generates on the cortex in the neurons. And that gets conducted down the cortical spinal tract and gets, you can actually activate the hand in such a way, right? So, but if you repeatedly stimulate using the magnetic stimulation, actually it changes the excitability of the neurons. So all neurons are excited, that they have got a baseline excitation, right? So if you stimulate them at a very fast frequency, you facilitate the excitability. And then if you stimulate at a slower frequency, it actually inhibits, so it becomes quieter, right? So the same way for transcranial direct current stimulation, if you do the anodal stimulation, which is the plus sign, right? So anodal stimulation causes facilitation of the cortical excitability, and then cathodal stimulation causes inhibition. So these are ways of altering so what we're doing is neuromodulation. So if you neuromodulate them and you train them in this modulated state for a longer period of time, we hope that it actually influences neuroplasticity. So that's what we're trying to do. So this slide just looks at what the sense of, well, that's me like more than 10 years ago getting TMS to my brain. Okay, so I've had it, I still lived, right? So it's safe enough for one session or a few sessions. So we are actually conducting studies in which using TMS, TVCS. So in any case, right, so at baseline, right, everybody has got your left brain will inhibit your right brain will inhibit your left brain, right? So there's a baseline inhibition all about. So if you have a stroke on one side, it actually alters the alters all these things, right? So, so there's increased inhibition coming from the stroke unaffected side, so which actually causes increased inhibition on the stroke affected side. So it's a double whammy. So what we're trying to do with brain stimulation is to try and rebalance everything. So we try and facilitate the stroke affected side and inhibit the stroke unaffected side. So that's exactly what we are doing in aphasia brain stimulation as well, right? So in aphasia brain stimulation, the stroke affected side is usually the studies that they have done is in actually the Broca's type of aphasia, so the non-fluent, the non-fluent type of aphasia. So they actually target the inferior frontal area, right? So we can go to the next slide.
Okay.
So that's RTMS. So these are all the studies for RTMS. So that's the red, orange, green, blue, yellow dots are the places that they have done studies in, and this is the effectiveness of the studies. So maybe suggest that there is improvement, but you see the numbers of the study are all quite small, right? So the number of patients that have tried this, like 45 in this total, right? So so 51 total. So not that many patients. So in other words, promising but not enough data. So for TDCS, similar story. They've tried to stimulate all over the place as well. This is the left hemisphere, which is the stroke affected side, and the right hemisphere, which is the stroke unaffected side. So they've tried to inhibit on the stroke unaffected side. A lot of people with aphasia have got big, huge strokes on the stroke affected side. So they sometimes just don't bother and they just stimulate the other side. So in any case, so many studies already. So again, numbers are small, promising, got positive data, but there's so many sites to choose from, we don't know which one is best.
Right.
So that is the end of the story.
That's the end of the story. So because I know one of the questions will be, where can I get this now, in Singapore?
I don't suggest that you try to get it on Amazon, although you can get it on Amazon, because truly we do not know where is the what is the best place to stimulate, right? Everybody is still unsure about the best protocol to be using to stimulate that.
Sure. Yeah. So there isn't like a just for clarification, there isn't like an institution or a clinic in Singapore where they can receive this form of stimulation, right? Brain stimulation, as far as you know.
Not
I mean, in the government setting,
not as a treatment for aphasia.
Okay. Yeah. So still tackle function. Come and attend conversation groups.
Yes. So speech therapy is still the mainstay of aphasia treatment right now in Singapore. Yes.
Yes. How time flies, and it's almost, we're left with just some final minutes, but we have more questions actually, or rather I have more questions, but to the Facebook audience, this is your last chance to ask any questions you have to Dr. Effie Chu, so please, just type it in. So yes, our team actually has a question about how do doctors communicate with persons with aphasia in the wards or in the outpatient clinics?
Yeah, so I get training from my speech therapist.
Nice, yay! Fantastic.
So hand gestures, So we do truly we do we communicate quite a lot with hand gestures. We try and keep the conversation simple, right? Don't expect copious amounts of information from them. So we try and also be in a relaxed atmosphere, so give them more time to express themselves, because we sometimes they get very thick and then want to get a lot of thoughts out, they cannot.
Extremely frustrating, because it's a foreign experience. It's very foreign when they are trapped in this new body, with a new kind of new brain. Very foreign and a lot of frustration. So thank you for making the effort to support their conversations. It's really important. So on that note, I just want to shout out as well to healthcare professionals. If you want to learn more about supported conversations, write in to us. We do conduct workshops for healthcare professionals, volunteers, corporate groups. We teach techniques using this approach, supported conversations for adults with aphasia. Basically, it's techniques that you can use to improve your communication with anyone who has a communication difficulty. So Oh, there's a question from Jeannie, Facebook audience. Can you share some success rehab stories? She wants to hear stories. Memorable, I guess, memorable rehab patients that you have encountered.
There are many. So I guess we're looking at stroke patients, is it? So stroke patients with aphasia.
With aphasia,
yeah.
Any stories that you might have? Yeah.
Just memorable story. So no names named, right?
Yeah.
So I think the obvious challenge is the younger ones, right? So we had a gentleman was a rock climber, so in his 20s, very successful, something to do, even he was doing something like a doctorate sort of work, right? So he went rock climbing, I don't know what level 7 rocks or something like that. I don't know what that means, right? But anyway, he had a fall, so he had brain injury and then aphasia after that. He made fantastic recovery. So he was a very active person. And we tried, so one of the challenges is to get such people back to work, right?
Yeah.
So and I think the communication part is really a great issue for them. Even though physically they might be very good, because at work a lot of times the communication is very much necessary. And he is a very active person, right? So I think his journey was quite impressive in the sense that he also had problems with seizures, right? After the brain injury. So there were a lot of things he cannot do anymore, right? So like climbing rocks, he's an active guy, so you cannot go back to rock climbing safely, just in case you have a seizure up there, right? Can't do very much in terms of swimming. So he, what he did was actually to go to go to a farm actually to work for a friend in some organic farm in Thailand. So so I think his persistence in trying to get himself back to work, and he actually explored multiple areas of work along the way, trying to to do everything possible to maintain that active lifestyle. I think that was a very memorable success story in that sense for me.
Yeah, inspiring. I really love the fact that this gentleman reinvented himself. He basically reinvented himself after this traumatic episode, and I like to think that he has emerged tops lah. It's not easy, because the next topic that I'm actually gonna very last bit I'm gonna talk to you about, ask you about, is your thoughts on the management of depression and anxieties for persons with aphasia, because and this story is a really nice lead into this point, because we see so many, especially the younger members, sharing their just their stress about not being able to return to work and some anxieties. Yeah. What are your thoughts on the management currently?
I think that's very, very understandable, right? Even for myself, right? So, or anybody, people even without aphasia, right? So being in situations that we're not comfortable with, we do try to avoid it, to say the least, right? Understandable that with communication problem, there's anxiety when you can't communicate properly, and the social interaction gets affected, it becomes awkward. Then there's a tendency to avoid, and then so by some people they get phobia, they get anxiety and anxious about it. There's this thing called linguistic. I saw there was linguistic anxiety phenomenon, and I'd say that these challenges are part and parcel of life, right? Everybody has challenges. Not everybody has aphasia, but definitely everybody has challenges. And It's important to be able to step out of that,
Mm.
right? So the social support definitely helps a lot. So for people with anxiety or with depression, we involve the caregivers a lot, right? So we also involve our psychologists and speech therapists a lot.
Mm.
So we get them to the caregivers to learn how the communication techniques. So we try to get the patients to step out of their aphasia, right?
Right.
We try to get them to step out bit by bit to try to get them to really integrate with the help of the caregivers. And we also teach the caregivers how to respond to the emotional expressions of anxiety and depression. Yeah, those are some of the things that we do. Some of them go into major depression, in which case we actually have to treat it with medications, but really medications don't help the social situation and the barriers that we face. So it's important to get people from.
Yeah. Thank you for that. Thank you for sharing that. I have actually encountered patients who are prescribed medication, but they do not want to take it.
Yeah.
I have encountered my fair share of those, and I guess with our team, we do our part by trying to provide a safe space. We really want to just shout out to anyone who is caring for someone who has aphasia, or if you yourself has aphasia, to know that you are really not alone. If you feel that you are up to it and you want to join some of our activities, you will get to meet other persons with similar challenges, and it's a safe space lah. So just know that you're not alone. And sometimes we like to think that having that space helps because they're able to share and have other people relate to their challenges. Because I think there's always this I remember very very vividly this one patient come to me and ask me, I know other people who have had stroke, but none of them are like me. Am I the only one who has a like a communication? Am I the only one who can't talk, or like has all these thinking word finding problem after a stroke? So I remember this one question very vividly, and I said, no, you are not, and yeah, please join our group and meet other persons with aphasia. Yeah.
And I really want to support that because I think it's such a fantastic opportunity to have that safe space to interact with. The people are not as judgmental as they might be, or you might perceive them to be at the outside world in that sense.
Yeah. Thank you so much. Yeah, thank you so much, Dr. Effie. It's such an honor to have you with us today, and to really round up. I can't think of a more fitting ending. You've answered so many of our medical questions, all these burning questions we have about medicine and treatment, and gold standards and evidence. So thank you all. Thank you so much. Thank you. And I also want to thank our Facebook audience. You have been wonderful. Thank you for all your questions. And especially for Facebook audience who have been supporting us since our very first episode. Well, let's see, our very first episode started with SLT, and I want to give a shout out to our volunteer Grace, who moderated the session. And then we interviewed our members with aphasia, Nasri and Shafika, who shared their recovery journey as well as their emotional challenges throughout the process. And we also have our music therapist volunteer, Michelle, and our social worker volunteer, Carmen, and our caregivers, our lovely caregivers, Catherine, Hazira, and Douglas. Thank you so much. And we have Daniel, Herman, Nicholas, who shared their journey with aphasia and stroke and TBI, and also our OT, PT colleagues, volunteers, Doreen and Ijin, and obviously our youth volunteers. And last but not least, of course, we have Dr. Effie today. So this concludes our entire Connecting the Dots, but don't worry if you missed it, because they are all on YouTube. So subscribe to our YouTube channel, QR code, or just search aphasiasg on YouTube and you'll find us. But importantly, we want to urge you, if you are an SLT student, if you're just anyone watching this, if you are interested in what we do, you want to volunteer, lend a hand, join us, join our community. If you know someone who has aphasia, or you're caring for someone who has aphasia, also QR code. This form will lead you to, you can find out what our activities are. We have plenty. Yeah, so this is us. You can connect with us through Facebook, Instagram, Twitter, LinkedIn. This is what we stand for. We are here to advocate for anyone who has a communication difficulty, especially persons with aphasia, because we believe communication is a basic human right. Yeah, and with that, we have come to the end of Connecting the Dots series. Thank you all so much. Thank you, Dr. Effie. Thank you once again.
Kudos
Good night,
to you.
everyone.
Yeah.
Good night.
Thank you. Thank you.
Thank you.